We're going to go over patient education in nursing. This is one of the most important things that you will learn how to do throughout nursing. Once you can educate patients, it'll help you understand disease processes better because I found that if you can teach about it, you can actually do it. So let's get into it. Patient education is, like I said, very essential. It's essential for patient safety, patient care, making sure that when we're sending them home, they're not going to come right back to us. Any rehospitalization within 30 days for chronic conditions, if it is related, will not be paid for by Medicare. Um, it's considered that the hospital did not do their job in taking care of the patient effectively. So it's really important that nurses educate and teach our patients how to take care of themselves at home. So it is a joint commission requirement. I'm sure you guys all know how I feel about joint commission. It is a voluntary certification that hospitals are getting. We are paying them to come in and tell us that we cannot have water at our desks. So a lot of patients are looking for that joint commission accreditation, so it's really important that we educate. But even without that requirement, patient education is the cornerstone of nursing. It's what we do that physicians don't do. It's what makes nurse practitioners different from physicians and PAs. We look at the patient as a whole instead of as a disease process. It leads to better self-management, it leads to reduced anxiety in patients, and then it facilitates better home care for patients. So historically, Florence Nightingale was, as you guys are, I'm sure, aware, the first nurse to really recognize client education as a very important function of nursing. She is the epitome of what it means to be a nurse. She focused on her patients as a whole and stopped looking at them as a disease process and really changed the way that the world looks at nursing. Now we're looking, instead of at diseases, we're looking to empowering our patients. Instead of teaching them to avoid sodium for their congestive heart failure because of how it affects their heart, we're teaching them how to avoid sodium for their congestive heart failure because of how it makes them feel, and that they will feel better if they avoid these things. They'll have more healthy, happy days if they avoid these things. So instead of just focusing on, well, you don't want your legs to swell or you don't want fluid to back up into your lungs, we're focusing on you'll be able to do things that you really enjoy doing again if you follow these strategies. So we're going to assist patients in using their resources, knowledge, coping skills, and we'll help them find resources if they need them. If a patient, when you're discharging, you're like, I really feel like they could use some extra education, make social work aware. We can get home care involvement. Home care can go in, and for about 3 weeks after hospitalization, it's like 3 to 4 weeks. Education is a good use of home care according to CMS. Um, After that, they have to have what's called a skilled nursing need, which is like wound care or management of medications or stuff like that. But for that first 4 weeks after discharge, that is a crucial time that we make sure patients stay at home. And our goal is to make independent patients who are able to take care of themselves and feel comfortable taking care of themselves in their own homes. Documentation. As I always say, documentation is critical. If you did not document it, you did not do it. It shows that you've done your education. Take credit for the things you do. If you've taught Mr. Jones how to avoid sodium, document. You taught Mr. Jones how to avoid sodium and he expressed understanding or demonstrated ability to look at nutritional labels and pick out high sodium foods. Um, Education is essential for reimbursement. If we get reimbursed, we get more money, we keep more staff. Unfortunately, healthcare has become a corporation instead of focused on the people. So the more money we're able to keep within the healthcare system, the more likely we are to get better staffing ratios. It applies to the nursing process. It gives us good record that if a patient does come back in 2 weeks and they say, nobody taught me, we can look at the record and say, well, Mr. Jones, it looks like here you were shown how to look at nutritional labels. What went wrong? We're never going to blame the patient, but we're going to say, well, you were taught. So where did we go wrong and how can we make this better next time? And then it makes sure that patient rights are recognized, that they have the right to understand their disease process, and we want them to have good outcomes. So the LPN is a critical tool. I hate to call people tools, but utilizing an LPN appropriately can make or break the RN's day. And we want to make sure everybody is working to the highest level of their scope of practice. LPNs are phenomenal at reinforcing teaching. Half the time they could probably do the teaching on their own, but as you know, scope of practice limits that. Um, so in NCLEX Hospital, LPNs can only reinforce teaching that an RN has initiated. However, that means you've done your initial teaching. The LPN, while they're doing wound care, can be teaching the patient how to do it. If the RN's already shown the patient, the LPN can continue that showing. The LPN can watch the patient do the wound care and intervene. As soon as an RN's done that initial teaching, there is so much the LPN can do. They cannot do that initial teaching and they cannot do discharge teaching, but they can reinforce every single thing the RN says. And as long as you've documented that you did it, the LPN can go right in after you and continue that teaching process. They are a plethora of knowledge, and it's really important that we utilize them to the highest level of their scope and not just treat them like they're there for medication and tasks. There's a lot that they can do that will really help make our day better, and it'll help them feel more like you're treating them as more of a team player instead of just a lackey to do what you don't want to do. The three domains of learning, most of what people think about when they think about learning is the thinking domain, the cognitive domain. It's that ability to focus, understand, and truly know the information. However, you cannot go into that domain unless you have that effective feeling domain set where it needs to be. If a patient does not feel happy or does not feel like the information you're giving them is relevant to them, they will not remember it. It means nothing to them. You need to meet them where they are, find out what they think about this process, what they think about understanding the information that you're giving them, and what change means to them. For example, if you've got Mr. Jones with sodium and his favorite food is potato chips, he is very unlikely to just stop eating potato chips. So instead of telling Mr. Jones that he needs to stop eating potato chips, maybe we can convince him to cut sodium somewhere else. Maybe he usually has a Diet Coke while he's eating the potato chips, and we can cut that out because it's just something extra he doesn't really care about, and he can switch that for a glass of water. Diet Coke has 70 milligrams of sodium. So when you think about it, that adds up with the potato chips. Or maybe we can get him to look at like a lightly salted Lay's potato chips instead of the fully salted. Making small changes is a lot better for patients than not making changes at all. And we have to meet them where they are. Because if we just say, Mr. Jones, you can never eat potato chips again, he's going to say, haha, I don't think so, and eat whatever he wants. And he'll end up back in the hospital over and over and over again because what you are teaching him does not matter to him. And then there's the psychomotor domain, which is that doing domain. If you've got a diabetic, don't just explain to them how to take a blood sugar, show them how to take their blood sugar. Watch them demonstrate back how to take their blood sugar. The more active we have the patient in their education, the better the outcomes are going to be. Now we have the cognitive domain, like I said. First, it starts with that knowledge. That is just the ability to recall prior learned information. That's when you're looking at history and you're memorizing all those dates, or you're looking at the bones and you're memorizing all the bumps. That is your basic cognitive domain. That's the thing that pretty much anybody can be taught how to do. What we're trying to do is get you to the comprehension where you're understanding the information, but not just there. We want you to be at that application level where you can use the data, then break it down, figure out what it means, and put it all together and come up with an idea. Being a nurse is not simply just remembering that congestive heart failure on the left side increases pulmonary resistance. I can teach that to anybody. Being a nurse is going, okay, so we've got left-sided congestive heart failure. It's increasing pulmonary resistance. Now I'm hearing crackles. What do I do? It's taking that knowledge and going, okay, I know this is what's happening. Here's what it's causing. What do I do about it? Anybody can remember the information. We need to learn how to apply it and really use it in order to keep patients healthier. With the affective domain, you've got that receiving. If they're paying attention to the TV, they're not going to receive that information. So we want the TV off. We want a quiet background. Do they agree to receive the information? If you approach them and say, Mr. Jones, I'm going to teach you about reducing your sodium intake, and he goes, hell no, don't teach him. He's not going to care or listen or learn anything. Say, I understand you don't want to learn right now. Is there a better time I can come in and talk to you? Is there something else about your disease process that you're concerned about? Meet them where they are. Do they value the information? Somebody who has lung cancer is probably not going to value if you're walking in and telling them they need to quit smoking, because to them, what's the point? They're already dealing with lung cancer. So learning if the patient finds the information you're going to give them important is really essential to teaching. And then you want to take all that information you have and determine a teaching plan based on the specific patient. Don't just say, all right, this patient has diabetes. This is my teaching plan for patients with diabetes. That's not meeting the patient where they are. That's not quality education. That's just, here it is. Psychomotor domain, like I said, the best way for people to learn is to first watch someone do it, then do it themselves, and then teach someone how to do it. If you can teach someone how to do something, you will recall how to do it. Actually, teaching in this program has made me a better student myself. So when you're studying, if you have a study group, everybody pick a topic and teach it to somebody else. That can really help you retain that information. And then you want to make sure that they're consistent with that skill. This is where the utilization of an LPN can come in. If you're teaching a patient how to check their blood sugar and you've taught them, you've watched them, now the LPN can come in the next day and watch them and make sure they're doing it right and report back to the RN. So just that consistency and making sure that we're making sure they do it right. And please, for the love of God, do not teach patients how to inject insulin on an orange, because a lot of patients, they learn that they are going to do the insulin into the orange, but then they never recall that they're supposed to actually inject themselves. So there have been cases of patients injecting oranges and then eating them to take in the insulin. So please, when we're teaching the patient how to do it on themselves. Facilitating adult learning is super important. You have to know how relevant things are to them. You have to let them have a role in their learning. Take advantage of any life experience they have. This is why when I was doing hospice teaching, the first day when I was coming in to do that evaluation to determine if somebody was even appropriate for hospice or if they even wanted hospice, the first thing out of my mouth was always, what do you know about hospice? Take what patients know and build on it. This also gives you a time to correct any questions that they may have or any information they may have wrong. A lot of patients with hospice thinks it means they have to stop all their medications and just die. And that's not true about hospice. Patients can continue their medications as long as they want. So finding out the information that they already know, whether it's right or wrong, is essential to being able to teach them effectively. Make sure they're willing and ready to learn. Maybe they just got a new diagnosis and they're not ready to learn about it yet because they're still dealing with what this is going to mean for their life. So taking the time to really meet them, as I keep saying, where they are. Focus on tasks or problems. Don't just come in and go, all right, Mr. Jones, we're going to learn about CHF today. Say, all right, Mr. Jones, today we're going to talk about your sodium intake and how it can impact your health. Break it down into little pieces that you can make sure they understand the full part of that piece and then move on to other things. Patients learn easier when it's broken down into small pieces. And then make sure they're motivated. If they don't care about what they're learning, they're not going to learn it. So ask them, what do you feel is important that you learn? Do you feel like it's important for you to do this? Find out what they need and make sure we're giving them what they need. Health literacy is super important. Literacy in America, just as far as reading, people read at about a sixth grade level on average. So when we're looking at health literacy, we're taking people who read at about a sixth grade level, and now we're looking at what they understand about their health, which may be even less, especially with the plethora of misinformation available on the internet nowadays. So we are going to take them where they are, and we're not going to use a ton of big words. If I'm talking to a patient, I'm like, Mrs. Jones, do you have orthopnea? She's not going to know what I mean. I guarantee at least 10 of you don't know what I mean. When I'm talking about orthopnea, I'm talking about a patient who gets short of breath when they're laying flat. You can ask a patient, do you get short of breath laying flat? You can ask them, how many pillows do you need to use to feel comfortable to sleep at night? This can give you the information you're looking at without using big words that your patient's not going to understand. And if you're using words they don't understand, they're just going to completely tune you out. So to promote effective learning, we want to make sure that they perceive that there's some benefit to their learning the information. We want to enhance their health literacy by using regular terminology. It used to be called layman's terms. Now it's called plain language. We're just using plain language. I am never impressed by a nurse who's using big terms in their documentation. Half the time they're using the wrong term, and it doesn't impress me. I want to know you actually know what those terms mean. So use plain language. Instead of saying patient was tachypnic with a rate of 54 beats per minute or breaths per minute, intercostal retractions noted. That's really great documentation, but when a patient looks at it, they're going to have no clue what it means. So say, Mrs. Jones was breathing rapidly with a rate of 54 per minute. Make it so that the patient can understand it, and it makes you look a lot smarter. Make sure we're being non-judgmental instead of coming in and saying, here's all the reasons you should quit smoking. And when the patient says they're not ready to, we'll go, well, why not? Instead of that, we're going, okay, Mr. Jones, are you ready to quit smoking? And if he says no, we say, okay, well, I understand that it's a difficult decision to make. I'm sure you have a lot of information, but I do have to present you with a little bit. Can you tell me what you know about what smoking does to the body? Coming in and just being friendly can make a huge difference. Make sure we're in a quiet environment. Don't have the TV on in the background. Make sure they're not just playing on their phone while you're doing everything. Make sure you've got their full attention and then repeat any key information. So things that hinder the learning process, fear, anxiety, depression. You're never going to be able to teach a patient directly after they get a terrible diagnosis. They will retain absolutely nothing. Lack of motivation. If they don't want to stop doing what they're doing, you will never make them stop doing it by educating them. Most of them have heard it a million times, especially when it comes to smoking. So just asking the question, getting the answer, and documenting that you did the education is all you can do. It doesn't mean that we don't try. It means we just accept the patient for what they say. Any environmental distractions like the TV, phones, psychomotor deficits. If they have right-sided paralysis and they're right-handed, it's going to be difficult for them to learn how to give themselves insulin injections. So maybe we need to work on a different plan. Physical discomfort. Make sure we're not getting them as soon as they wake up in the morning, super late at night. If they're in 10 out of 10 pain, we want to make sure they're comfortable so that we can take the time to educate them. And then poor timing. If a bunch of family members in the room, that's not the time to educate. We want to get the patient when they're alone, when their stomach is full, when they're in no pain, and when they're ready to learn. And it's okay to ask, and it's okay to document. Attempted to teach regarding new diagnosis, patient not available at this time due to whatever. Addressing these barriers, impaired cognition, we bring the family in, we educate the family, we educate any caregivers that are going to be present. Language barriers, always use professional translators, do not use family. Family does not always translate what you are saying. I do not speak Spanish fluently, but I understand a lot of Spanish. I can know if the translator that's a family member is not telling their loved one what I'm asking. I asked a older lady if she was sexually active because she was coming in with some pelvic complaints. Her granddaughter was embarrassed to ask her if she was sexually active, so she kept reassuring her grandmother that everything was fine. You have to have that professional translator to know that the information you are giving is being relayed and that the information that you are getting is actually what the patient is saying. It's really important for all aspects of patient care that we make sure we have good translation. Visual and hearing impairments. Make sure we're doing one-on-one teaching, facing the patient, have their full attention, and are using any special equipment they may need, glasses, hearing aids, magnifying glasses. If they're struggling with pulling up the insulin appropriately, maybe not using a syringe and vial is a better way to go for them. So we're adapting things for patients. Any emotional concerns. If they're afraid to give themselves an injection, that's going to block their learning. Maybe there's something we can do to make the injection less scary for them, or we can talk through those feelings before we're teaching about the injections. Cultural differences. Some cultures believe that illness is a punishment from God. Some cultures believe that certain illnesses are caused by hot or cold and that the cure for them is the opposite. It's important we know what patients believe is causing their illness so that we can help them understand what they need to do. And then any physical discomfort is really going to detract from learning. So we want to make sure that they're comfortable. Do they need to sit up in bed because laying flat makes them uncomfortable? Are they having abdominal pain that we can treat? Is there something we can do to make them more comfortable and therefore more receptive to learning? Fine and gross motor skills, fine are those dexterity things. Gross is just the ability to move around. Optimal learning environment, being non-judgmental, adhering to all our ethics, respecting patients' feelings, address any biases they may have, and any biases you have. And being culturally competent does not mean assuming that every person from a specific culture is going to feel a certain way, but it's being open to the fact that they may. Making sure we've got privacy, making sure the TV's off, making sure they're comfortable temperature-wise. And then every education session should be tailored to the patient. Like I said, you cannot just come in with, I have this script that says, this is my diabetes education and this is what we're going to do. It will not work for everyone. It may work for a few people, but it will not work for everyone. Then we want to do our repetition and feedback. Like I said, with repetition, this is where LPNs are essential. They can do that repetition. They can teach patients, but they cannot do the initial teaching. So make sure that you document that you did that initial teaching. And an LPN who's taking care of the patient the next day can absolutely repeat everything. And getting patient feedback. How are you doing with this? What are you understanding that I'm saying? Can you show me what I just showed you how to do? All those things so that you can address things in real time. And if with the teach back method, patients may think that you're doing it to judge their education. No, you tell them, I want to know where the gaps in my teaching you were. It's the same thing I do with you guys. I am not asking you questions and testing you to find out where you are going wrong. I'm doing things to find out where I need to address the gaps. It's the same thing with patient education. Where am I going wrong with teaching you? What are you understanding and what are you not understanding so that I can help you? Group instruction. They do things like this for maternity. They'll have group Lamaze classes and all that kind of stuff. It's a great way for multiple people dealing with the same thing to learn. Individual is great when you're working with a patient who needs a specialized kind of care or who really needs that interaction that they can get your full attention. Teach back. Having that patient explain everything back to you in their own words. Don't have them read it verbatim off a sheet. They won't remember it. They need to tell you everything they understood in their own words so that you can figure out the gaps. Use digital technology, videos, different like infographics and stuff like that can really help with learning. So nursing process and teaching process are similar, but the nursing process focuses on all the overall care. The teaching process focuses on those learning needs. Assessment part of the teaching process is understanding their needs. How does the patient learn? What don't they understand? What do they already know? What might their culture impact? For a Jehovah's Witness, if you're doing pre-op teaching and you're talking about, the possibility of a blood transfusion, you need to know that they're most likely going to say no. That does not mean you do not ask, because they may have broken from the church. They may have different views than what their church is telling them. We always ask, but we are understanding if the answer is different based on their culture. The analysis, we're going to prioritize what they need to learn. We're going to take all the information we just gathered about what may impact their education, and now we're going to start making an idea of what we need to learn. Then we're going to do our plan. What's our educational plan? If they're diabetic, our plan needs to include how to check their blood sugar. So we're going to do all those things and put together a really good plan. We're going to do our SMART goals. Just really coming up with that plan of how to educate them. Then we're going to go, here's the SMART goals. So they need to be specific. They need to clearly define expectations. We cannot just say the patient will walk down the hallway. It should be the patient will walk 50 feet down the hallway. That's specific and measurable. It may not be achievable for the patient. Maybe 25 feet needs to be more of the goal. It needs to be relevant to what the patient needs. You need to ask the patient to have their involvement in these goals. And then the timed part isn't a time frame that they're going to accomplish it. So maybe we'll start small and say, okay, Mrs. Jones will walk 25 feet down the hallway with standby assistance by Thursday at 4:55 p.m. It doesn't have to be that specific of a time. It can be by discharge. It can be by Friday evening at end of shift. Just make sure we're making a really specific, measurable goal that's achievable for the patient and that we have a time limit on it so that we can know if we're meeting that goal. If you just say Mrs. Jones will walk down the hall, okay, but there's no way to measure whether Mrs. Jones has met that goal or not because we don't know when we want it to happen by. Implementation is the actual doing of the education. We want the patient to be actively participating in their education, asking questions. We want them to repeat back what they've learned, but really encourage those questions. As I keep saying in class, there's no such thing as a stupid question. The only stupid question is the one you do not ask, because you can't learn if you don't have all the information that's relevant to what you need to learn. And then evaluating, that's the teach back method. That's when you're having the patient teach it back to you so you can evaluate how good you did with your teaching and how well the patient understood. And then we're going to reassess and maybe figure out a different way to teach information that they didn't get. So the key takeaways are that patient education is essential. We have to have a goal. We have to be interactive and have the patients able to make the decisions. It helps make them more self-sufficient, keeps them at home. We need to make sure that that affective domain is taken care of, that the patient is motivated to learn and they're in a place to learn. And then we want to overcome barriers like health literacy and emotional concerns, or else we'll never get good patient education done. All right, that's it for patient education. If you have any questions, please email them to me because I will be compiling everyone's questions into another PowerPoint that I'll be posting about a week before the exam. Thanks.